The person who approved your injection may have never been in the room with you. 5 minutes on a video call or less. A signature, done. That's the only medical exam standing between you and a needle full of something you can't see. I'm Dr. Kate D., founder and medical director of Glow Medi Spa, and this is Med Spa Confidential, where we expose the risks, the red flags, and the outright illegal practices happening inside med spas right now, because you deserve to know what's actually going into your body before you say yes. Today, I'm joined by Jamie Weiland, a nurse practitioner in Texas who goes by the legal NP. She spends her days where medicine crashes into the law, reviewing cases that end careers and leave patients disfigured. She knows exactly which corners med spas are cutting, and she'll tell you what those corners cost. This one gets uncomfortable fast. You'll find out what a registered nurse legally cannot do no matter how good her injections look. You'll learn why the consent form you signed may protect nobody. And you'll find out how many vials of Hylenex we require in the fridge before a clinic ever touches filler. Stay until the end when we get into the doctor now facing murder charges over a patient he never even met. So, Jamie, thanks so much for speaking with me today.
Yeah, thanks for having me.
So I was hoping we could dive into what is advanced nursing, what is nursing, and what's medicine? And is there a difference? And I want to talk about scope of practice and who's allowed to do what, because it's just such a morass. People get super confused, and there are so many people out there kind of crossing all these boundaries. And is it okay? Is it not okay? So I would love to talk first about, really the difference between RN and NP training and experience and what their licenses are allowing them to do. How about we start there?
Yeah, great topic. So the biggest difference between nursing practice and nurse practitioners is not who's smarter or who has more skill. It's all based upon license, scope, authority, and responsibility. So a registered nurse practices nursing. Okay, their role is assessment, monitoring, intervention, patient education, advocacy, escalation. That's why I teach all the time that escalation is a huge part of nursing, and they carry out ordered treatments. Okay, so that's kind of the basic fundamental way to describe nursing.
They carry out ordered treatments, meaning someone with prescribing authority ordered a treatment.
Correct.
And they can carry that out, but they can't prescribe it themselves.
Correct. They cannot practice independently at all in any state. And so a nurse practitioner is a little bit different. That person is also a nurse, but they practice at an advanced level. So with an NP scope, we can assess, diagnose, order, we can interpret testing, labs, we can prescribe medications, we can even create treatment plans and manage patient conditions within our education and certification on top of state law and in your clinical setting. So it's kind of like a tiered approach to it, because when it comes to advanced practice nursing, we really have to fall back on our state laws and our state statutes. And that's really important. I think that's where a lot of nurse practitioners get bogged down. So the difference isn't just simply RNs follow orders and NPs give orders, because that's totally oversimplifying it. RNs absolutely have independent duties. They're required to recognize changes, question unsafe orders, make sure we're escalating concerns. And our job, in my opinion, is essentially that blanket of protection of your patient. We are first and foremost patient advocates. So, but then NPs also carry provider level responsibility. So for diagnosis and decision making, and that means some legal exposure shifts. So the NP is not just documenting about what happened or implementing a plan. They're also creating the plan. And so they can choose differentials, deciding. And then another little random off is a physician assistants, right? So we kind of have them too, and they're seen generally as equals to NPs, but their training is not. Our training is vastly different. And the NP side is more based on the nursing model. Okay. And then the PA side is based more on the medicine model.
NPs are generally governed by the nursing board.
Mm-hmm.
Their license comes from the nursing board. Physician assistants are generally governed by the medical board, and their license comes from the medical board. The overall total amount of education, at least college and grad school, is approximately the same.
Mm-hmm.
Generally, a master's level degree. We can get into education. We talked about this as part of our kind of getting to know each other. Like, there's this very big differentiation between the different master's programs and how people are getting that degree. And so that's also kind of a fraught area of conversation. So let's table that one for now. So generally, the idea is you're supposed to have at least a master's level degree of education and training to allow you to make diagnostic decisions and have prescribing authority.
Mm-hmm.
Yeah. So in the med spa world, that means that NPs and PAs can perform a good faith exam, which is sort of our generic legal term for that initial intake, history, physical assessment and plan, where you're looking at their body, their skin, whatever their situation is, and you're making an assessment and you're recommending whatever procedure that would be, right? So RNs are just not allowed to do that. They don't have that prescribing authority, but a PA or an NP or a doctor can do that. I would love to know your opinion on telehealth for good faith exams, and can that be done? Should it be done? The laws are all different in different states, but during COVID, when we all kind of shut down and stuff, I tried to do some consultations and the good faith exam myself remotely, and I found it completely inadequate for me. I just felt like I really needed to see people's skin. I really needed to be able to look at them more closely than that. What's your opinion on that?
Yeah, so I think aesthetics is a different world, obviously, because you have to pull on someone's face. You have to feel their skin texture. You need to see it up front. And, in my personal opinion, these cameras that we have are so filtered that I don't even think a lot of the times you get someone's real skin. It probably looks a lot better. And so...
What are you talking about? I've got no filter going on. I swear to God. Okay, but sorry.
Neither do I, but I bet you there is some sort of filter. So I think telehealth is fantastic. I'm going to be honest. I think that it has a great reach to people in need. I think that it's affordable. And I think that it also gives practitioners a way to connect with people, right? Because nurse practitioners were originally made for rural communities where doctors didn't reach, right? And so to just be an extender of that physician, that was the original plan for nurse practitioners. And so I think telehealth is great. I think that it's great for benign conditions. I think it's great if you've got a cold, if you've got a sinus infection. But just like everything in medicine, and things start to creep in, we start pushing boundaries. We start, well, if they can do it, I can do this. And so, where is the line? Where's the line? Is it gray? Is it black? I don't know. And so I think we are really pushing into that. And like I always say, medicine and law are very reactive. And it takes years. So it takes something bad happening and then years of litigation to get a firm stance, and you can't do this. So I think that's kind of where we are with telehealth right now is, there was that nurse practitioner that got in trouble for prescribing, fetal demise prescriptions from a different state to a woman in Texas, and they're suing her now. The state of Texas is. So I say give it 5 more years and you'll probably figure out what you can and you can't do.
Right. Well, I think for aesthetics, the thing is if you're consulting and a patient comes to you and they're like, what do I do about this terrible rash? It came on overnight. It looks really angry, whatever. If you feel like, oh gosh, you really need to go in and have that seen. If you're the one being, if that's your responsibility to assess that person and decide what to do, and you feel like they need to be seen, you'll tell them, well, you need to go into your doctor or to the primary, or to the urgent care, to the ER, if you think that that's necessary. Mm-hmm. And I think that what telehealth's being used for is in these med spas where there are only RNs. The telehealth GFE is just a sign off on, say, Botox or laser hair removal, whatever. is no one in the clinic that can do an assessment in person. This is the assessment. And so when that assessment isn't adequate, the only person who really knows that is that 5-minute, telehealth NP visit that really they're just charged with, can this person get Botox or not? And, so there isn't a mechanism for following. I mean, maybe there is one and that I just don't know about it. But I think that is being used a lot as kind of a rubber stamp, 3 to 5 minute at most visit that the RN's paying the NP to provide. And a lot of those companies don't specialize in aesthetics, so they're not actually even, assessing for that. But I digress. So I would love to talk about this case that established NPs and their independence in the first place, because I think it's really interesting. So it came from 1983. And it's Sermchief versus Gonzalez. I don't know if I'm pronouncing that right?
You did.
There's no reliable way to know if a med spa is following safety standards or cutting corners until now. The Med Spa Board certifies clinics that prove they're doing things right. Verified products, licensed staff, and actual medical oversight. It's the difference between rolling the dice with your skin and knowing exactly who's holding the needle. If you're looking for aesthetic treatments, go to medspaboard.com to find a certified spa near you. And if you already have a med spa you love and they're not certified yet, please send them our link. Med spa owners, getting certified does more than build patient trust. It should also save you a ton on your malpractice insurance. Do the right thing and go to medspaboard.com. Keep listening, keep asking questions, and stay safe out there. And it was 2 OBGYN nurse practitioners at a family planning clinic. And that, I think, was rural, right?
Yes.
That's why they were there. And they were doing a bunch of things independently on protocol just to reach more patients, right? And can you tell us a little bit about that case and what that resulted in?
Yeah, so I love that case, actually. So 2 nurses, Barbara and Mary, they were working in a community clinic. I actually don't know where it was, but they were providing, like you said, family planning. Okay, just basic contraceptives.
Yeah, I think it was Missouri.
Okay. And, assessments, and they worked off a protocol sheet that was, put together by their supervising physician. And you're right, the Missouri Medical Board essentially came in, and there was a complaint filed that they were practicing medicine without a license. And so their argument was that the nurses were diagnosing, treating, and crossing the line between nursing and medicine. So they were separating that line. And the case went all the way to the Missouri Supreme Court, all the way up. And the court actually sided with the nurses at the end. So the court looked at what they were actually doing. They were not independently practicing medicine. Okay, they came to that conclusion. They were working under written protocols with physician collaboration. And that was a big word in that case, was cited, that was defined. And they were practicing within the authority of Missouri's nursing law. So why does this case matter to us today? Sermchief actually established that nursing practice can evolve over time. And that's what a lot of people speak to with this case, is that just because a task is clinical, advanced, or something a physician could do, it doesn't automatically make it the practice of medicine. And that was very loosely defined prior to that. And so the legal question isn't just, is this a medical task? The better question at the end of the lawsuit came down to, does the nurse have the legal authority, training, protocol, and scope to do it? And so, that was back in the 80s, and things have changed drastically since then between nurse practitioners and doctor roles and nurses roles. So this case was a fantastic example of nurses or nurse practitioners being utilized in the way that they were supposed to be, and then just kind of confirming it through the state Supreme Court.
Yeah. So I've been trying to sort that out because it's putting together this course for the Med Spa Board. So we now have a full legal compliance course for med spa owners and practitioners. Yeah. So it's worth 4 credits for nurses and doctors, just in case anyone out there wants to do it. So putting that together, one of the things I learned was, first of all, nurse practitioners are practicing technically by the law, advanced nursing. Mm-hmm. And doctors are practicing medicine. And the law, however, doesn't clearly define what's nursing and what's medicine. And there's obviously this giant overlap. And like, where is that line? And I think some states define it partially, and other states don't even address it at all. Mm-hmm. And so it can be very, very confusing for people like, well, what can I do? And what can I do? And until there's a case, we don't know. Like the area is somewhat gray. And so this just came up for me this week because there's this great med spa in Virginia that applied for med spa board certification. And they have nurse practitioners who do have independent authority in Virginia. But then I found, this one case where laser hair removal was specifically defined as medicine and not nursing. And according to that case, if you're doing laser hair removal in Virginia, you actually have to have a doctor overseeing you, even if you're a nurse practitioner with independent authority. But then I talked to a lawyer who's like, well, that's not my understanding of it. And so I'm like, okay, that's confusing even for, I think, lawyers or for anyone in Virginia. It's like, well, what's what? And, and so depending on who you ask, you might get a different answer. Mm-hmm. My understanding, though, is there are lots of independent NPs in Virginia who are doing laser and Botox.
Yeah. So that comes down to state law. And,
right.
So that's the whole reason for my channel. That's the whole reason why I started the Legal NP, was to help bridge this gap between medicine and law, because we work so hard in school just learning medicine or learning nursing that, like, once we get out there, we're practicing under the law, but like, we don't know what the law is. We know what our preceptor told us. We know what our company tells us. But are our company's policies up to date? Are they following state statutes? Are they updated for case law? And so my number one thing for anybody in healthcare is, if you have a question, answer it yourself, and don't just learn how to find the answer. And so that's essentially why I created my channel, because law is really confusing. It's really confusing.
I think that the other side of this, besides people pushing their own scope, is companies pressuring you to practice outside your scope, taking on more independence when you weren't trained to do that. And there can be pressure from the other side of like, well, they don't want to hire a doctor, so they're going to make their NPs do stuff that they don't even feel comfortable with. That's very possible too. I think that's very common. Mm-hmm. So I don't know. So yeah, so I always encourage people to talk to, well, first of all, check their local state board. So the nursing board and the medical board. And of course, for estheticians, the cosmetology board. There are just a ton of rules there too. But also to be able to talk to their local, like a state healthcare attorney who actually understands this stuff, because a business attorney does not, right? And even a lot of healthcare attorneys who are dealing with hospitals, they also don't understand the outpatient sphere or the med spa sphere. So it can be really hard to find someone who actually does know the answer, right?
Oh, yeah. And then there's contract law, there's business law, there's, all of these, just like medicine,
Mm-hmm.
You don't want to go talk diabetes to a plastic surgeon kind of thing. So, there's a lot of laws the same way. And so, we see dangerous things happen all the time in business and in medicine. And when those things collide, you just have to have your ducks in a row, because, we see cases all the time that just tear apart someone's life, and they were doing something wrong that they didn't even know they were doing wrong. So
would you be up for talking about the Tennessee versus Redonda Vaught case?
Yeah.
Because that's pretty recent. So that was just in 22. Maybe you can introduce that case and talk about the waves that.
Yeah. So that's obviously a huge case for nurses, right? So Redonda Vaught was a nurse at Vanderbilt. She intended to administer a sedative, Versed, for a patient. And I believe, if I understand correctly, she was a float. So she was kind of like a resource nurse picking up. And she went to help a patient in a PET scan, I guess was having anxiety or something, wanted to give a little bit of sedation. She used an override function in the medicine cabinet and mistakenly selected VEC, which is a paralytic, vecuronium. And
vecuronium.
And where this turned criminal, and a lot of people don't understand this, a lot of people are very emotional about this case. And so she overrode multiple safety warnings. Okay. She administered the medication without scanning it, and she didn't monitor the patient after. So, that's kind of where they got her. And the patient ended up dying from respiratory arrest. And so, unlike most medication errors, prosecutors pursued criminal charges in this case. And how they got away with it was they charged her with criminally negligent homicide. And I think she got acquitted of that. I don't think she got charged with that, but they also got her with abuse of an impaired adult, which is a random charge that we don't hear very often. But so why it happened was they alleged that she caused mass system failures. Okay, so bypassing the drug system and the drug dispensing protocol, she put the patient at risk by not scanning the medication, which is a system that the hospital has. So, it was just this cascade of events. And so the biggest question wasn't whether an error occurred, because we know that there was. It was whether the conduct crossed the line from negligence into criminal behavior. And that was what they had to prove in court, and they did not succeed. So they did not succeed in convicting her with homicide. So that was one of those really dramatic tester cases where she was unfortunately used to kind of prove a point. And so I think it made a lot of healthcare workers open their eyes nationwide to be like, holy cow, like if I accidentally kill a patient, I could go to jail for murder. So it's a case.
Was there ever an explanation as to why she hit override, didn't scan it? I mean, that's a lot of, that's a lot of sort of blasé skipping over big things that were there to prevent you from doing exactly what happened.
Yeah. And her defense team, chalk that up to the staffing conditions and how that was an unfamiliar Pyxis system for her, like unfamiliar medication system. And so, yes, I mean, she admitted to overriding it. She admitted to, bypassing it, and essentially chalked it up to, hey, you put me in a situation where I didn't know where I was. That wasn't my normal area. And so
she hadn't been trained in this system or anything. I mean, it's just,
So here's an example. In the ER, we override meds all the time. Like, we have someone that's seizing, we just hop in, type in the drug, grab it, and if something were to happen and I was to accidentally pull VEC and mean to go give Ativan to someone, that would come back on me, because I know that I'm not supposed to bypass that. But if the doctor hasn't ordered the medication or put it in the system because they're standing bedside with the patient. And so you've got both worlds here, right? You've got nurses that are like, I do this every day. Like, this is my job. And then you've got nurses that are like, she should have never done that. That was the safety bypass. So that's why this is so emotionally fueled. And so she actually just did a tell-all recently. I haven't seen it, but.
Can we watch it on Netflix?
So I think it was like on either 60 Minutes or NBC. Yeah, she did a whole tell-all interview. One of her first.
I mean, I'm sure it's absolutely traumatic. I mean, there are, medication mix-ups where, there's some sort of temporary effect of whatever it is you gave the person. So for anyone who's listening to this, who are watching this, who doesn't know what vecuronium is, like, the only time when we use that is when you're intubating someone. Mm-hmm. You have to paralyze and intubate them. You also sedate them at the same time so it doesn't freak them out that you're paralyzing and intubating them. But you would never give anyone else a paralytic. It would stop them breathing and they would die. So you can't stop someone from breathing unless you're about to breathe for them. And so it's hard to imagine grabbing that under any circumstances other than you're about to intubate a patient. Mm-hmm. So That I'm sure. I wasn't super familiar with this case before, preparing to talk to you. It is really hard to imagine as a physician. It's like so hard to imagine grabbing the vecuronium. It's just
Well,
like,
in the
wow.
color coordinate, like usually the tops are brightly colored and they're labeled too.
Yeah.
So,
Yeah.
and all those things were brought up.
But to be essentially a temp covering, and if you're not trained in the system, then why would there even be vecuronium available? But then, of course, it makes sense that it was in this, emergency only thing. Maybe the real question is, why is the Valium or the Ativan mixed up with the vecuronium? Like why is that in the same cabinet?
And I don't know all the details of the case. It's been a while since I read that case, but I think those were all points, and it was a procedural area. So it was perfectly fine for vecuronium to be there, because we do intubate for IR procedures and stuff like that.
Yeah.
So, just a grave mistake. And mind you, that's not the first nurse I've known of personally that has given a paralytic to someone and killed them. So, I mean, it's happened
really?
in not to me, but to a nurse around me in my career. So,
yeah, there was this case when I was a resident at a local hospital here in Seattle where there was an IR case, so an interventional radiology case. The stuff that was on the sterile table was drawn up and put in little cups. And there were little cups of, I think it was either contrast or anesthetic. I can't remember. But on the same table, there were little cups of chlorhexidine for prepping the skin. And that got confused. And someone, quickly drew up, injected the chlorhexidine into this person's veins. And ultimately it killed them a few days later. It was the most awful thing. And that case was a huge, huge case. This was a long time ago. This dates me because it's the 90s. And basically, now with all like that drug cabinet, there were all these things that are done now to label things and systematically keep track of things so that would never, ever happen, even just to the point of not ever using a clear skin prep. The skin preps are a different color. They cannot be confused, right? But over the last, I would say 30 years, there have been a huge number of checks and balances that have been instituted to address medical errors. Back there was big report about medical errors. People die of medical errors. So, but we're getting kind of into the weeds here. But I assume she lost her license and she's now talking about her experience. And
she did. Mm-hmm.
Yeah, it's terrible. So getting back to this kind of scope thing, because I do think that it's really it's really interesting to look at what is a skill that you learned versus what you're allowed to do legally. And then also what you're allowed to learn in practice. Because so for instance, RNs cannot practice independently. They can learn how to do certain things like inject Botox or do laser, but they can't decide to do that on their own. They have to actually carry that out as an order from someone else. And there's this huge problem in the medical aesthetics industry where people learn a skill and they're like, well, hey, they may not even have any degree, any license of any kind, or they're an esthetician and they went to a weekend course. In Texas in particular, where you live, there are these weekend courses that are marketed to anybody. And they take a weekend course. Oh, well, now I have this skill. I should be able to put up a shingle. Kind of any skill where you're like, oh, well, I learned how to do knife sharpening. I'm going to set up a knife sharpening business. You don't need a special license for that. Right. But people learn the skill and they think, oh, well, all I need is to, have an Instagram and start selling this as a thing. But that's basically practicing medicine without a license. And not only is that illegal, but that's a felony. Everywhere, that's a felony. So, but then I think that this more importantly is people who, maybe they have an NP and they learn a skill, but where does that boundary end? Where is it you really can't be doing that? Liposuction, sedation, there are a lot of people doing awake liposuction that they're doing now. And like, is that something an NP can just go out and do on their own? I mean, I wouldn't feel comfortable. I mean, as a physician, I'm just telling you, I wouldn't feel comfortable doing that. Is that a skill you can just learn and decide you're going to put up a shingle and sell it?
No, so skills are different than knowledge in my world. So, and even in the legal world. So just because you were taught something doesn't mean you have knowledge of it. Okay, so having knowledge is knowing the ins and outs of it. It's like knowing how to dissolve filler if you put filler into someone's face and occlude an artery. You know, you have to understand the pathology. You have to understand, you know, the facial diagram. We have dental assistants injecting Botox in our state, you know, and that's just a whole nother, you know, thing of weeds that we can get into. But just because you possess a skill doesn't mean that you necessarily possess the knowledge that surrounds it. And I think that's kind of what knowledge takes time. Skills you can learn and you can take a course and learn them, but knowledge and seeing patterns and recognizing patterns takes time. And that's why an MD or a DO, a physician, is the ultimate like tiered ranking professional in medicine because they have the most time under their belt. They have the most risk. They are your go-to. There's no one above a physician. There's no one, you know, so you have to know and possess the knowledge to perform the skill.
And I think, you know, built in, I can only speak as a physician from my experience, but built into our education and training is knowing where your expertise ends and where you need to get a consult from someone else, because this is not my area of expertise. So, I mean, I came from the world of breast cancer. I could tell you a lot about that. And when people would ask me, you know, about cardiology questions or whatever, I'd be like, that is not, I need to send you to a cardiologist to know that, or, you know, get a cardiac workup before you have this surgery, whatever. I think that one of the things that we learn is our limitations, you know, and I really think that it's really important to understand, like this came up the other day. We had a patient who came in who had a couple different autoimmune diseases and had a very unusual reaction to a extremely low level, what I would call very low level, safe, non-ablative laser. And this came up like, well, you know, when do you ask for additional advice? Can we go ahead with people like that if they have any unusual diseases? What's okay to do? What's not? When do I need to make sure that they check with me, the medical director, before proceeding, right? And that's where, you know, an esthetician will have no idea. What is Sjogren's? I don't know what that is, right? And the PA, and I have a PA and an NP work under me, and it's like, if ever they have any question, they ask me, like, right? If it come like, you know, can this person have that? Like, it comes up with things like sculpture. We love sculpture and we do a lot of sculpture, but like, you know, that's a big deal if somebody has an autoimmune disease or if they have trouble healing or if they have any unusual thing about them. So I think that what's hard is like, if you don't know what you don't know. So you're out there doing something. Well, I know how to do Botox, and, you know, until someone comes in and they have a history of myasthenia gravis and you'd have never heard of that. You don't know, right? You don't realize that that's a big deal. You can't just do Botox on someone like that. And there are all kinds of things like that where if you don't know about it and you just treat everybody the same, then the one in a blue moon person who's an exception to this, you won't catch that. And I think that that's so important. And that's part of our working together. Like, my team, I have, you know, my NP, my PA, my master estheticians, and honestly, my front desk staff, staff is very, very highly educated in this stuff because they've been working for me like forever. And they know when to ask, like, hey, can you look at this before I book this patient? Because, you know, this is unusual. And I think that those kinds of checks and balances are what we're looking for in the system in general, not just in medical aesthetics, but in medicine as a whole. Is if we are like, you know, I always say, like, why can't we all just get along? Everybody stop berating everybody. Like, there's such a turf battle between like the plastics and the derms. They hate people like me because I'm not a plastic or a derm. But there are a lot of doctors who are like anti, NP and PA. And I'm like, why? They're amazing, and like, why can't we all just work together? And so, but that's how the system's supposed to work. If you ever have a question, if you're not sure, do not proceed. Ask your collaborator, ask whoever you're working with, whether it's someone, at your exact same level or your supervisor, even just an outside consult. It's so important. And that, I just think that would prevent so many of the bad outcomes that we've seen. I know that, we've beaten this horse to death on this podcast, but like the Jennifer Cleveland case, which is in your backyard in Texas, that person Amber Johnson, who's now has multiple felony counts charged against her, she didn't know what she didn't know. And people think, ooh, vitamins, they're good for you. We'll just put vitamins and electrolytes in your IV and that'll be good for you. I mean, I can't imagine a more dangerous thing than sticking weird things in an IV and having it flow directly into your vein. Let's see what happens. What are your thoughts on that?
My thoughts are that takes humility. And I think that that's really hard to come by nowadays. I think as a nurse practitioner, I find myself defending my title all the time. I don't want to be compared to other nurse practitioners that have made huge detrimental errors. I don't want to be compared to a nurse practitioner that only, that has an MSN, which is the same degree I have, but only went to school for 3 months. Like there's just this comparative narrative. And it really takes you to put your ego aside to put the patient first. And I think that that's really hard to do. And I think that comes with time, because if you look at these new practitioners or these new nurses, they're gung-ho, they're excited, they're confident, they're ready to go. And then you put them next to a 20-year nurse and that nurse will be like, oh, you are too brave. You are too brave. And I think those recognizing of patterns and those slap in the face moments come with time. And so if you come out of the gate rear end, you're going to make a mistake. And unfortunately, in our world, we deal with patients' lives. And so I think it has a lot to do with humility.
Well, we could use a lot more humility in medical aesthetics. I'm just going to tell you. I mean, when I first learned filler, I was sweating. Like it still makes me sweat. It's still my whole next topic that I'm going to do is about filler and why I talk people out of it. But people are learning injectables like it's painting, like it's a beautiful, like a skill that they're being artistic and, oh, look at this beautiful skill that I have now. I'm like, you should be freaking out about where that facial artery is right now. Like if you're thinking about this beautiful face, you really need to be thinking about the facial artery. And its variations and how safe are you? And oh my God, because I didn't prepare this picture for this. Essentially, I'm getting, okay, sorry. I didn't prepare this, but really smart, highly educated, highly skilled injectors have hit the facial artery and caused massive disfigurement. And so if you are a brand new injector and you think that, woohoo, I'm so excited, the more the better, I'm going to talk her into, 3 syringes instead of 1 or 5 syringes instead of 3, you're just having a higher and higher risk of disaster, right? Mm-hmm. And I'm gonna share this anyway, right? That this slide that I was hoping to share with you. So I'm just going to share this briefly because this is an infographic I prepared for one of the talks I've given. And I think that it illustrates really clearly, not to say, if you want to just put my education and training in there, I had, college, med school, and then 4 years of residency and then a year of fellowship. So I was up in that light blue section in there, but in that amount of time, you see so much good and bad. It worked, it didn't. You get scared. And that's like extra many, many years of being scared to do things because they're so crazy. But I think it's really important for people to realize that those 2 years master degree, that gives you the authority to make independent assessment and decisions and stuff. But you have to know you're out on a limb now, and you've got to be super careful. And, realistically, there are estheticians out there practicing medicine without a license all over the country. And I absolutely respect my estheticians, but you have to realize that that's not enough education and training in order to practice medicine, And when you don't know the disaster that might be around the corner, it's really so dangerous. So, I mean, in my practice, we've had one vascular occlusion in the 12 years we've been open, and it was recognized right away. We treated it right away. Patient did fine. I've interviewed many people who don't know that you really need to have, at the Med Spa board, we require people to have 16 vials of Hylenex in the fridge to treat a vascular occlusion. You need at least that. In the one that we did, I think we used 14 on that one case. But I interview lots of people who don't know that. And they're actually grateful for when, we interview all the medical directors for the certification process. And they're really grateful, like, oh, wow, I didn't know that. We've never had a vascular occlusion. I mean, we prepared for it, but we've never seen one. And so I think that having that humility of like, oh, wow, thank you. I'm happy to learn from you. Like, that is so important. So we should all be learning from each other. And I think the reason to have a doctor somewhere in your back pocket, even if it's not on staff, is like, if you have something and you don't know how to deal with it, you need to have a friend who you can call or text them and say, hey, I got to run something by you. And for me, one of the first things I did when I set out my practice, I have two very close connections with oculoplastic surgeons who, God forbid we ever had a vascular occlusion that involved the retinal artery, they would be able to take care of that. I don't know how to do a retrobulbar injection, but I have two oculoplastic surgeons who I am good, close friends with, who I can text and they can help me if ever I needed to send them a patient. And I think that's so important. And most of these med spas out there don't have any ability to do that.
Well, and I think a huge part of that is also, humility, determining your level of comfortability. And the other thing is that there's nothing worse than someone else causing a problem and that problem being dropped off on your doorstep.
Right. And people don't want to deal with that at all. And I will say that's the number one complaint that dermatologists have about med spas. They generally hate med spas because med spa causes some complication and then the patient goes to see their dermatologist. And of course they see all the worst cases. I mean, the truth is like there are, millions of treatments going on in med spas where nobody ends up at the dermatologist because the vast majority of times it's okay. And you just need to know where that line is so that you know when to refer out and to not just create negative vibes out there because you might need that dermatologist, to help you. So it's not okay to just kind of set up shop down the, and just say, ha, screw you. I'm gonna take all these patients and not have. I think a
lot of the lawsuits that I'm seeing that are in aesthetics and med spa world is one, either not referring in a timely manner, like you realize that something was wrong and you didn't call anybody for help. Yeah. And two, a lot of the people that are involved in litigation, like, yes, you have an occlusion or you have a massive burn or whatever can happen, right? That's super dramatic. The risks aren't being discussed.
Yes.
And I think that's a huge part that we need to be okay and comfortable with saying, hey, you're an African American. This laser may affect you differently than it would another Caucasian patient. And here's the facts of it or whatever's involved in that, and I don't think we do that. And I think that's where people get stuck with informed consent lawsuits. I was never told that it could burn my face off.
Right. It's the number one lawsuit in medical aesthetics is lack of informed consent. That's true for filler. So, no one told me that I could get a vascular occlusion and then you got one. And vascular occlusion has to be included in every single filler informed consent. Patients have to be aware of that. I can't tell you how many people have come to me and they want filler. They've had it many times before elsewhere, but I'm the first person to mention vascular occlusion to them. And the other thing is we only use dissolvable fillers in my practice. We will not use Radiesse, which is non-dissolvable, or Bellafill, which is non-dissolvable. I think those two personally should be taken off the market. I think they're way too dangerous to be injected in humans because you cannot treat a vascular occlusion. Now, some people argue, with Radiesse you can treat. You can't really. You can't really break it up. And I just think that you should not be using those. It's bad enough to use a hyaluronic acid filler with the possible risk of you wouldn't be able to get it all dissolved. But that's why you keep at least 16 vials of Hylenex in the fridge. But like, there are all these places just setting up shop, ordering filler. They don't really know what they're doing. They don't really know the risks. They don't know the anatomy, and they just take that risk.
The Groupon shops, we call them.
Yeah. Yeah. Well, there was just a Groupon shop in Texas that was shut down. Pure Indulgence. They were running Groupons for years for Botox. This wasn't for filler, and they were ordering fake Botox off the internet. That was the only way they could afford to provide the services for that cheap.
There's a couple of those federal investigations going on. There's a couple of people. One thing I do want to just give a little legal pearl to your listeners. So informed consent litigation is very common in med spas and aesthetics. But one thing I see when I review these cases is, yes, they've got a great sound consent and it was pretty and it was done by their lawyer, but there's nothing in your documentation that you spoke those words to that patient. And so you want to make sure that in your documentation, especially for a true informed consent, because at the end of the day, the signature doesn't matter. The signature proves that the patient signed a piece of paper. It doesn't prove that they were actually informed on the risks. What proves that they were informed on the risks if you verbalize or type in your document that, you know what, I had this conversation with them. I told her that, they could get vascular occlusions, they can get burns, whatever it is. And so just always adding those both pieces, that's how you protect yourself.
Mm-hmm. Yeah. So informed consent is supposed to be a discussion of the conduct, how the procedure is done, the benefits, the risks, and the alternatives. Yep. And the patient has to be given the opportunity to say no once they understand the risks and benefits, right? Yep. And the alternative of not doing anything at all also has to be listed in the list of alternatives. And the signature is just saying, yes, I had this discussion with my doctor or my provider. And what's being skipped is the entire conversation, right? So it's in the system. The patient's expected to sign it. Some places even send it to the patient ahead of time, and they've signed it ahead of time, or the front desk has them sign it. None of that is adequate. You actually have to talk to them about that, and it has to be thorough. Now, I will say when I first started injecting Botox 12 years ago, I actually talked about the black box warning that it could kill you. And, it's true back then. There's a black box warning. If you have enough of this stuff, it could kill you. Well, and I would explain to people the reality is we are putting teeny tiny amounts in teeny tiny muscles. And even sometimes we have to put more because those teeny muscles don't get paralyzed. But, and so if you took the entire, 20 units of Botox and stuck it directly into your diaphragm, it is not going to paralyze your diaphragm. Okay. And I don't go through that anymore. I go through everything else, all of it. Droopy eyelid, bruising, all the things, asymmetric, blah. But I don't talk about death anymore because really there has never been a death from actual Botox cosmetic. There's been deaths. There have been people hospitalized with botulism from fake Botox.
Well, in the PMR space, I review a lot of long-term ailments and stuff like that. They use hundreds of units when they're injecting limbs and stuff like that. So relative in the amount of Botox that you can systemically inject, your face is pretty low.
Yeah. So the amounts that we use now, the amounts that they use in headache clinics is way higher.
Mm-hmm.
And that kind of freaks me out a little bit. The limit I heard just the other day was one place uses a limit of 120. I thought another place used 140. That's a lot to get in one setting. And I advised my friend, I was like, look, just have the 120, wait a good 2 weeks and then get more later. I wouldn't do more than that in one session when it's elective, you know?
Just because you can doesn't mean you should.
Right. It's too dangerous. You don't want that much to be ever possibly reaching your bloodstream. Right. Mm-hmm. But, typically most people are getting, 20 to 50 units of Botox in their face, and it's totally safe. It's, now, could you get a droopy eye? Sure. Yeah. That black box warning really came after there was a scientist who basically got a hold of some crude botulinum toxin, purified it himself, injected himself and his wife and his friend and their wife, and they all ended up on ventilators.
Ooh.
I don't think any of them died, but that wasn't real Botox. That was just someone doing it privately.
And those are the ones people hear about too. So those are the ones that put the terror in people. So
people have been hospitalized with botulism a lot in the last couple years from fake Botox that these illegal spas and illegal practitioners are buying off the internet. And frankly, anyone can buy anything off the internet at any time. So, either of us or, my college age kid could go on Alibaba, order something, inject it in themselves or someone else. And, someone who decides to do that to make money and for a living, I'm going to just do this. There have been multiple arrests of people who are doing that. I don't know what that is legally. Reckless endangerment, that would be at least, negligent. I don't even know. But
so I don't remember what they were charging. It's a federal indictment. I'll have to look that up. I honestly don't know because I'm just thinking of the one girl that got. There's
so many. It's hard to. Yeah, there have been many, many of these cases. There's just one in the news just recently. I talked about on the podcast, but it's like it's criminal. It's essentially assault.
As it should be. You are duping the public.
Yeah,
knowingly, willingly. Yeah.
Yes, and risking their lives. Right.
Mm-hmm.
So, it's interesting because, let's going back to the Jennifer Cleveland case where that non-medical person, Amber Johnson, who killed Jennifer Cleveland. So she wouldn't have known any better, but she had a medical director who is an actual doctor who would have known better, would have known the risk, should have known the risks. So this is still an ongoing case. He has also been charged with multiple felonies, including murder. Yeah. And he didn't ever see the patient, but he was the medical director for this person who did not know what they were doing. And so it'll be really interesting to see that case play out. But the point is, the doctor is supposed to know what the risks are, right? And, it's interesting. When I first wrote the book, the book came out 2 years ago. My doctor friends, a lot of my close doctor friends read it, and they were like, no way is this stuff happening. And I'm like, well, wait. It's happening, and it's really, they're like, it's so scary. Oh my God, I can't believe people are doing that. I'm like, yep. And people are paying money for it. And the thing is that if you go to an illegal place, pay money, get a treatment, and you're happy with it, and you walk away, you could say no harm, no foul, but sooner or later, someone's going to die or someone's going to be disfigured. And just because you got away with it and that person got away with it doesn't mean that wasn't one of the scariest things that could have happened, right?
Yeah. Left runs out. Runs out.
Yeah.
And the federal government will find you. I tell people that all the time. If you think you're being sneaky, you're not.
Yeah.
You're not. They're just being quiet.
Yeah.
It takes one little squeaky mouse to ruin your whole, and that's why we have whistleblower laws and rewards for that exact reason, because they want people to get rid of people like that.
Yeah.
That are doing negligent criminal behavior. So, yeah.
Yeah.
People are great.
On that note, I think that this has been a really great discussion. I hope that everyone who's watching or listening kind of gets the lay of the land of just how there are some really stark black and white Do not, order fake stuff off of Alibaba and practice medicine without a license. Clearly, that's pretty black and white. But what we've covered also is just this kind of breadth of gray area where if the system's working properly, everyone's working together and within the scope of their knowledge and training and their license. And so when you are not sure about something, do not proceed. Ask and form those relationships. Even if you're on your own in a solo practice, form those relationships so that you can have someone to ask, because we all need that. I need it. You need it. We all need to have that collaborative teamwork in order to take care of patients properly. So hopefully that's our main message here.
Yeah, it's a great message.
Yeah. Thanks so much for speaking with me on the podcast today. It's been awesome.
Yeah, thanks for having me.
Thanks for listening. If this episode opened your eyes to something you didn't know before, share it with someone who needs to hear it. Subscribe so you don't miss the next one. And drop a comment telling me your biggest takeaway. I actually read them all. Join me on this mission to keep you safe and push this industry to do better.